you. I think because we have quite a bit of time today, et cetera, let's all introduce ourselves at the beginning. Sometimes we do it as we switch off. There's a young white, she, her, hers. I am on the 1115 waiver health related social needs team. And so that means I'm in the Medicaid space. Oh, hey, there's some people from my old work here. Lovely to see you all. Really awesome to be in this space. So I used to attend in different roles, et cetera, in the background. So anyway, just really glad to be here and thank you. And then I'll turn it over to Amelia and then Tara, and then we'll come back to me.
Good morning, everyone. I'm Amelia Reynolds. I use she, her pronouns. I am also on the health-related social needs waiver team. I'm going to focus on the climate-related supports piece of that and present on the housing supports for kind of the first time that we've really taken it to a space like this. So excited about that. So I'll take those two pieces, and then Tara is here to support me in any follow-up questions. But Tara, go ahead and introduce yourself. We're happy to have you.
Hi, I'm Tara Gray, she, her pronouns, and I just have to say before anything else, hi, Dolly. I have not seen you in forever, and in the 6 months that I've been here at OHA, I'm so thrilled to see you. So yeah,
and
as Amelia said.
Sorry, to give people reference, Tara was one of our CBO partners in COVID, and now she works for OHA. So shout out to you, Tara.
Thank you, Dolly. And actually, that's what brought me here to OHA, is that partnership and just how much I enjoyed working with OHA and with Dolly in particular. So I am thrilled to be here, and I am here, as Amelia said, just to support if there are questions about housing. Thank you. And back to Teresa.
Thanks, Tara and Amelia, of course. Yeah, this is a fun group. Both Tara and I are from the Lynn Benton Lincoln region, and we know I think we know a lot of the same folks here, and this is just lovely. It's so amazing. This is why I work, is engagements like this. Well, I mean, I do need to pay, for housing, food, and things like that. I guess that's the first reason, but this is what gets me out of bed in the morning. Okay, so we're going to talk about health-related social needs. We're going to specifically talk about climate, housing, and outreach and engagement benefits for Oregon Health Plan members. So really exciting. Some of you may have quite a bit of background on some of this. Oops. Oh, it's doing sort of a fade switch between the slides, and I wasn't used to that. So sorry, that took me a little aback. But we're going to go over just a little bit of the basics. So what are health-related social needs? So health-related social needs are the basic needs a person needs to optimize their health and well-being. So that for us in this particular context is climate, so things that impact extreme weather or wildfire smoke. Housing supports, outreach and engagement services, which is connections to resources. I'll get into more about that later. And then coming in 2025, nutrition, food, extremely important as well. We're not going to talk about nutrition today. So if you have any questions about the future of that benefit, though, we'd love to come back and bring those folks with us there. One thing that we like to just talk about right off the bat with health-related social needs, we recognize this is not a benefit for all Oregon Health Plan members. And so we just want to be really clear up front so there's no false expectations for folks, that they understand that there is a complex eligibility structure for these. And in some cases, or in some opinions, that can be a little bit unfortunate, my own as well, that it's a little bit complex. So we start out, they must be an Oregon Health Plan member. And then there is this HRSN covered populations. There's 6 sort of different populations in that group that they must be a part of in order to be eligible for then the benefits. And then there is benefit specific criteria. That's why we have a whole hour today, is that we want to talk about the benefits, but also how do we support people getting access to these benefits and trying to simplify it for members as much as possible. So how can we provide the language, the supports, the forms, the process in a way that increases access becoming as low barriers as possible within the parameters that we currently work in, which is this eligibility structure. So our timeline for the health-related social needs supports, we started in March. So Climate is live, along with a few activities for outreach and engagement. And then on November 1st, we have a whole lot of activities for outreach and engagement. I think it's going to be pretty exciting for a lot of the folks that I see on here that might be potential HRSN service providers that can get reimbursed for some of these services. So we'll get into detail about those activities, et cetera there. And then housing. I mean, housing is the big topic around the nation these days. So what housing supports are we going to make available for our members and how they can access them? On November 1st, they will be able to access this benefit as well. And then I talked a little bit before about nutrition. January 1st, nutrition will go live. We can come back with more information there. And then there is this HRSN covered population. You may have heard it said as YSHN. So young adults with special health care needs. These are for 19 to 20-year-olds as of January 1st. And as long as they're eligible under the different eligibility criteria, they are eligible for any of the 4 benefits that I talked about before as of January 1st. I do want to note that in the future, we are looking to phase in additional benefits, especially around housing. There are different things that CMS has approved for us to go live and implement at some point in the 26-27 years. And then our waivers last for about 5 years, or for exactly 5 years, not about. And then hopefully after that, all the health-related social needs will continue as well. That is the plan. So I am going to turn it over now to Amelia to talk about climate and then I think housing. And oh, I am not looking at the chat. Are there any questions that I can answer first? Okay, it looks like you've got most of it there. So Amelia, I'll turn it over to you now.
Yeah, great. And great question, Mercy, that yes, this first part is kind of just a review of what we were here to talk about. I think that was back in like the March, April time frame that climate's been live for 6 months. Small portion of outreach and engagement has been live. But what we really want to focus on today is highlighting what the changes are for climate that will go live November 1st. And then housing, that's the new benefit that will be available starting November 1st. Then outreach and engagement is going to expand. So yes, this is building off of something that's already happened. This is part of that like phased approach as we're moving forward. So yeah, go ahead. I see your hand too.
Thank you for answering my question. Can you hear me, please?
Yep, we can hear you.
Okay, so the reason I'm asking because early this year, we were on this platform and we were encouraged to apply to assist in this program. So my question was basically based on the fact that are you trying to encourage us to apply again to be part of this, or you just coming back to talk to those people that were already funded to do this work? What is the whole goal of this whole thing?
The main goal of this is to give organizations that might interact with Oregon Health Plan members who are eligible the right information to know what is available. We know that housing supports, as an example, are not going to be available for everyone. So being able to kind of clarify, like, yes, in this situation for this member, housing might be a good fit through HRSN, through their health plan. In other situations, you might have to say, HRSN is not going to work for this individual. We need to find other resources to support their housing need. For those that applied, I do want to separate real quick too of what may have applied for community capacity building funds directly through coordinated care organizations. Those are the funding awards to get ready to provide these services that took place, and they should be announcing who was awarded. When we talk about folks who might be HRSN service providers, that is separate from kind of that process, and that is more of like a contractual relationship with the community or with the coordinated care organizations, our health plans, to deliver these services. So for outreach and engagement, which Trissa will talk about, that would mean connecting folks to these benefits, helping them request the housing benefit, helping them request the climate benefit. And then for housing, like our housing providers would sign up to work with our coordinated care organizations and OHA to help deliver these services and do some of the tenancy support, which I'll get into. But that's kind of the goal, is just to make sure that this is a new benefit and that more people can understand who is likely eligible to receive the benefit.
And just do the work because they have go hard to do it, or because they're going to have funds to do it?
Both. If you're acting as a HRSN service provider, you are getting reimbursed to do this work. That requires that agreement, like registering as an HRSN service provider, having a contract in place with a coordinated care organization to deliver services. So there's that one piece. And we know that this work and the sharing of information and helping people doesn't always fall neatly in that category. And I think members getting good information from trusted folks is still a benefit. But yeah, the paid portion of this does have to be fully as an HRSN service provider, either as outreach and engagement or one of the other services, but that's a formalized role.
I appreciate you taking the time to explain to me. I just want to know how to spend my time when I wake up in the morning and come to work.
Yep, I understand that, Mercy. I appreciate the question.
Thank you. Have a great day.
So climate, this is a little bit of a repeat. So just acknowledging that as we go forward, I will highlight the pieces that are changing for November 1st. It's very small. So on the next slide is kind of just a recap of the goal. This is devices to help keep folks safe during extreme weather and wildfire smoke. Because today is supposed to be about 100 degrees in the metro area, I do want to acknowledge that this is not a fast program. This is through a health plan. You have to go through and request to be screened and all of that stuff. We'll talk about that as speed. This is part of Medicaid. It moves not as quickly as we'd like. I wish that it could go faster. We're pushing it to go faster. It's Medicaid and it's a bit slower. So I just want to acknowledge that if somebody is requesting these devices, it might take 2 to 4 weeks to get them. It's not going to be rapid distribution like same weekend. And yeah, you can go to the next slide, Teresa. This is just an overview. There are no changes to the devices that are available. So still air conditioners, our air filtration devices, mini fridges for folks who use temperature controlled medications like insulin, portable heaters for when we get to winter, and then like generators or backup battery supplies. Those are the portable power. All of that's the same. What's changing is that now folks can get this as of November 1st. So we have to wait until November. But what's changing is that folks can now get assistance with installation for all of the devices, not just air conditioners. So if somebody maybe needs support with unboxing, and some of these are heavy, getting them set up in their residence, that is going to be expanded to all devices. So that'll be a change. On the next slide, we talk about who is eligible. There are some very slight changes here. I think really it just is more detail. We are better at explaining ourselves after doing this for 6 months. So we're trying to learn and clarify what we're doing, since it's complex. So the first group here, adults or youth who have been discharged within the past year, we've changed this to an HRSN eligible behavioral health facility. We've now listed very specifically the types of facilities that fall within that definition. Before, it was a little bit more vague of institutions for mental disease and greater than 16 beds. Now we have better classifications. Again, that'll be a change for November 1st. So there's going to be better detail there. It's not listed on the slide, but it'll be better defined. The adults and youth released from incarceration in the past year, that is staying the same. Being involved with the Oregon child welfare system at some point in their life, same thing. Dual coverage. The last thing I'll call out is the difference. We've separated here at risk of becoming homeless and individuals who are HUD homeless. This is for a very specific reason. Also clarified our definitions, so those are more easily known and identifiable. So this will apply to housing as well, so you'll hear it a couple times. Individuals at risk of becoming homeless. This is more clearly defined by 2 factors. You are 30% below the area median income. That number is set annually by Housing and Urban Development. And then you attest that you basically don't have a support network or the resources to prevent you from becoming homeless. So it's 2-factor, but much more simple and straightforward. And then this is one is the same as before, but just noting that for climate, we've separated out into 2 categories, meet the definition of HUD homeless. And then Weishin, young adults aged 19 and 20 will be the first phase starting in January. So that's not really a change, but just clarifying that piece. So again, the two changes, better defining the eligible behavioral health facilities and substance use facilities, and then separating out at risk and defined as HUD homeless. So on the next slide, it is all together. Not, again, this is all just together, not much has changed. Must be in a covered population, have a health condition that relates to one of the device types, and then the additional eligibility requirements. And yes, we'll send out the slides. So a couple things here on these requirements. They must not already have a device that meets their needs. Pretty simple. Can't request an AC. You already have an AC that's working for you. If you don't have an AC, great. You do need to reside in your own home, which is a non-institutional setting. So that means that it can't be like a licensed long-term care facility or an adult foster home. Basically, if the facility is already licensed and required to provide things like AC, heat, we can't duplicate that and provide it in the same space. So that's the limitation there. Yeah, exactly what Trissa just dropped in the chat. Thank you, is what I was verbalizing. So there are.
Michael had put a chat in, so I wanted to respond there as well. So.
You got it. I was keeping tabs on them a little bit, and so if there are, there's a better definition that'll be coming in November 1st that provides more detail about the non-institutional settings, but there already is. This is already in existence. It's already in rule. So as far as folks who says in their own home or primary residence, there are many situations where, for example, somebody could be residing in an RV and have access to consistent electricity and still meet the definition of HUD homeless. So it doesn't always, I think, align with how folks might view a community that is houseless, but we're going by the definition here. There are many cases where somebody is still sheltered, still has a space to use these devices, but meets that definition. So there's a little bit of nuance there, but I understand that when you see it kind of in these simple sentences, it might appear that it contradicts, but I think there's a lot of folks that we can still support that meet that definition, who have a place to safely use these devices. All right, this is the pause. That's the first thing. It's a review of climate, highlighting a couple of the changes. That's chunk of information number one. Chunk number two will be housing, and that's probably the biggest session of this. So I'm going to pause and see if there are any more questions or if I miss anything in chat, or if many of our other hosts want to jump in with questions. Or it's like a pop quiz situation. That's how I always view some of these presentations. It's like you never know what questions you're going to get, but it's exciting.
And just a reminder to folks that I will be sending out in the follow-up email, per usual, the slides, any important links that are shared, and also Amelia and Chris's email addresses. So it's okay if you are like, I have a question, but I can't think of how to do it right now because I need time to process. You will have the opportunity to check back in with them if questions arise after this as well. So please take a deep breath, no pressure. We are here to help.
Perfect. Okay, and then you can continue to put stuff in chat, like raise hands. We do not mind being, I don't even like to call them interruption, like just making sure that we're getting the questions answered as we go through. Okay, so I'm going to jump into housing. I will say I'm going to keep this relatively high level because it's a lot of information. It's new, and there'll be more time for us to talk about this because we still have about 60 days before this is available. So a reminder, this does not start until November 1st. Okay. Also, when we prepare these benefits, we work through a lot of decisions and things that have to be kind of finalized by a certain point. So most things are final now, so we can finally start communicating it consistently. So that's what we're doing today. So to start, we are going to start with a relatively narrow group of individuals who are able to access this benefit, and the hope is to expand as we move through the next couple of years. So I just want to frame it that way. So essentially the goal of housing supports here is to help folks stay in their current housing and prevent homelessness. We also want them to be safe and to be able to feel comfortable in their own homes. That's going to be another piece of this. And Heather, correct. It is excited engagement. That's how I choose to interpret it. Thank you for giving a better phrase to it. So what is part of these housing supports? What do we mean when we say this housing benefit under health-related social needs? Kind of from a high level, it really means rental assistance for folks to stay in their currently identified housing, tenancy services, which is sort of like case management for housing, can work with landlords and things like that. And then what we refer to shortened as just home mods, but home accessibility modifications and some other pieces. So I will go into those in more detail, but that's kind of the overview of what we're going through here. All right. It might sound like I'm repeating myself, and that's true because this is complex and we're going to try and hit all of these different aspects as we go through. So number one part of the housing support that I talked about, this is the housing tenancy sustaining services, kind of like case management. Think about it as somebody to help work with a landlord who might be challenging or maybe is great, but you just want some support advocating for yourself. We can try and work through things that you might need to be successful in the space that you're currently living, making a housing plan to make sure that you've got a plan in place if things, maybe income changes or something like that. So it's really something to put a plan in place of how do I stay in my house? What do I need? How can I work with my landlord or agreement in place to keep it that way? The second piece, this is I think what folks are most interested in, that we hear a lot about, get a lot of questions about, rental assistance. So rental assistance, again, for folks who already have identified housing, this can be for up to 6 months. And this is inclusive of past due amounts. Meaning, if somebody was past due 2 months, you can cover those past due months and then 4 months moving into the future. So it is the 6 month total, whether it's 2 months back pay, 4 moving forward. With the rental assistance, so if somebody is receiving that rental assistance, can also help with utility setup costs for the 6 months or covering past due of 2 amounts, 4 months moving forward. And then if there's any storage fees that are associated with rent or with the current living situation or something like that. So I will pause there as that's the second piece, but I see a hand. Go for it. Jump in.
Hi, good morning. My name is Amina. I work for SACO. This is really great news because we deal almost 90% of the clients that we deal with come here for rental assistance. How do they apply? Well, how can we get access for this?
Great. I will cover that. Perfect question.
Thank you.
So same thing with climate. So for all of these benefits, because this is part of somebody's health plan, these are essentially benefits that come through Oregon Health Plan, which is delivered by our coordinated care organizations, and then for our open card, so folks that are not enrolled with the coordinated care organization, through our third-party contractor, Essentra and IN, who actually deliver these services. They're the ones that are actually going to be essentially funding through Medicaid the payment for these services, and I'll be working with what we call health-related social needs service providers. These might be organizations like yourself that are already doing housing supports and helping with like payments to landlords. But these are going to be, this is when at the beginning when I was talking about the official formalized role of an HRSN service provider that is working with coordinated care organizations. It's kind of like a 3-step process. Coordinated care organizations, they receive the Medicaid funding to serve Oregon Health Plan members. They can reimburse folks that are doing housing support with them. And then the member gets, like their landlord gets paid directly for rental assistance. Those requests for support can go through an HRSN service provider. They can go directly from the member to the coordinated care organization. They can go from the HRSN service provider to the coordinated care organization. Members can start the process themselves by calling their coordinated care organization or Essentra But I think really the best way is to make sure that folks have all of the information they think that they'll need to get ready to request this kind of in place. That's where we hope that our HRSN service providers or folks doing outreach and engagement, which Trissa will talk about, will help folks get all of the information needed so that they're ready to go. When they request this benefit through their health plan, it can move more quickly because they've got all their stuff in place. So it is through someone's health plan, either a coordinated care organization or a Centra. Our goal is that we can have some organizations that can support people, because I think many of us have dealt with healthcare organizations and there can be some challenges. I still rely on calling somebody for help a lot of the time when I'm dealing with anything healthcare. So hopefully that answered the question. That's a great question. It is a health plan benefit, so going directly to the health plan. And then the third category is going to be what we refer to as home modifications, but medically necessary home accessibility modifications. It also includes things like pest control, heavy duty cleaning. If somebody needs a hotel stay while this work is being done in their residence, that can be covered too. And we use the example of like ramps for mobility devices or grab bar installations in bathrooms, like things like that are great examples of things that are covered under that. So that's kind of an overview of the benefits that are available. We're going to move into eligibility. This is where I know that things can get a little bit more complicated. So we've tried to follow the same format that we have for the other HRSN benefits, and I will walk us through it. Some of it might be repetitive. Again, just trying to make sure that we're walking through the same steps over and over again, because it is, acknowledging it is a bit complex. So for rental assistance and the associated utilities or storage fees, and then the tenancy services, the requirement is it's an Oregon Health Plan member who's currently housed and needs support staying that way, has an official lease or agreement with their landlord. So it does need to be a document that it makes their living situation kind of official there, and then meet that at-risk definition. So that is the income that is 30% or less than the area median income of their area. Same thing I covered for climate. And then that self-attestation that they don't have the resources or support network to prevent them from possibly becoming homeless. And then the third piece here is this is part of a health plan. So we really want to tie it to, or we have to tie it to somebody's health needs. So it's what we call a clinical risk factor, but having one of these health conditions that would qualify them. So it's having an already identified place to live, meet the income requirement, and then meet one of these health conditions that puts folks at higher risk. I'm going to pause there for a second on this one, because I see some good stuff in the chat, and I think somebody wanted to step in and answer some of the questions. I'm going to pause.
Thank you, Amelia. There are a couple, and I am not good at keeping up in the chat, and some things are really just kind of better out loud. So the comment from Michael, the question from Michael about working with affordable housing providers, as long as you are, as long as the organization works with clients who are eligible and based on our eligibility criteria, and also have a written lease or agreement. So if there's an agreement, a rental agreement, and rent to be paid, and as well as utilities to be paid, then yes, the benefit could be used for that. So just as long as there's rent and an agreement, even if it's an organization that you that actually owns these properties or manages these properties, that's not really a conflict of interest. It's more just, it more depends on having that written agreement and then meeting the other eligibility criteria. And then another question I think that is a little complex to answer is Marianne's question. So can people who own their own home or live with a family member qualify? So no, we're not able to assist with mortgage payments, and then because of that, the utility assistance and the other services that come with the rental assistance also don't apply. But one of the exciting things about this housing benefit is that there are people that can be served who aren't traditionally served with other housing assistance, such as people who are doubled up with family members. So as long as there's a written lease or that that person could get a written lease or agreement with the landlord, you can be served if you're doubled up. And that's to me, that's one of the best things about this benefit that really makes it stand out, because that's not something that's not a type of assistance that's been able to be really regularly accessed for most people. There are a couple of other organizations and types of programs that will pay for doubled up, but I think it's pretty rare. Were there other questions?
I see Lisa's got her hand up. Go ahead.
Yes, thank you. Wonderful presentation. So my question, looking at 1, 2, that's pretty standard. Number 3, that's where it seems like it gets a little complicated. So I'm wondering, so if a family is, for example, receiving benefits from another organization that usually doesn't kind of mix in this world of clinical risk, what is going to be the criteria that organization can contact the CCO and they can walk through that with them? Or is this putting families where they need to then divulge certain clinical information? And we know some of the stigma that's connected with that.
Is it okay, Amelia, if I go ahead and take this?
Please, yeah.
So we've got a request form. There will be a housing request form. There will be a climate request form. There already is. Each of the benefits will have a request form, and those go from the member or from the connector to the CCO, and then the CCO does the remaining assessment. So nobody has to disclose a specific clinical risk factor. Is there anything you would like to add to that, Amelia?
Yeah, I'll add one thing. Just knowing that like we had there must be a clinical need tied to an air conditioner as an example. So we need to prove that like this is going to help somebody's health condition to have that type of device. I use climate as examples because, to be honest, that benefit is a lot more simple because it's a device. So sometimes I use that as an example, then try to like move it up to a different benefit. It is on the health plan to confirm with the individual the clinical piece of it. So I wouldn't worry too much about the service provider getting kind of like stuck in working through that negotiation. The responsibility lies with the health plan to work with the member to confirm that they have the health condition that relates. The hope is that this might also be already documented in their like chart that they have this condition, and the health plan can confirm it. And so the individual wouldn't have to necessarily tell you the full details about it. The health plan would follow up.
I do appreciate that. I think I'm just worried because I can see this it sounds really amazing, but being in the clinical world, it just seems like this is opening up a lot of risk for people and their families to divulge information, especially if they're not knowledgeable on the requirements. So we're talking at a provider level here with a lot of us, but I'm talking about those families that are going to hear about this benefit and they're not going to perhaps understand. And so we got a lot of organizations out here in our state of Oregon, rural as well as otherwise, that may not be following what this has to say when it comes to this clinical aspect. And that's my fear, that OHA doesn't have the ability to monitor that at the family individual level.
Yeah, I definitely hear that concern. And I think that's one of the like tensions that we're trying to work through as we do these benefits, is we're taking stuff that has traditionally not lived in a Medicaid, like medical world, and we're shifting it into it. And so I think it's definitely going to be a learning experience in these first couple of years to see like how it goes. Do we need to change? What more resources are available? So yeah, I agree with you entirely. Like this is definitely new. It's moving folks into a space that we've not really done before. It's kind of the cool piece too of the waiver, is that we get to try new things. And when you try new things, there's more risk involved. So yeah, I don't, not that I'm trying to like give a perfect answer, but you're right. You're totally right. And I think we'll keep that in mind as we move forward. One of the other pieces is when you become an HRSN service provider, there are specific agreements that get put in place and ways to that members can authorize the sharing of their information to try and build in some of those protections. So we'll learn from it. We're going to see how it goes, and we're going to learn from it. And yeah, I also thank you for raising that concern, because I think it's definitely one that, yeah, not only you will have.
Amelia, I just want to jump in here as I put on, I was thinking about Dr. Carey. We have a medical director who works more with the clinical risk factors than I do, that's for sure. And just kind of channeling her too, as she was working through these, the idea was to make that not the limiting factor. We have to, per federal regulations, CMS, tie this to a health outcome. But the idea is the clinical risk factor is actually broader. It looks really complex, but if in practice, if we just take out a few things and say anyone under 6 years old, anyone over 65, anyone pregnant, so there's a pretty big chunk there. And then you don't even have to look at complex behavioral health need and developmental disability, right, et cetera. So trying to simplify it in practice and make that not a limiting factor, and make it so a member can self-attest that they have one of these and not that specific condition to share with everybody in their care, I think is really important. So you make of course, that's an excellent point. Just agree with everything Amelia said. And I just wanted to say that we're trying not to limit there, and we're trying not to have a member say exactly which one they have and send those forms everywhere as well. So hopefully they can say they have just one, and the CCO will take that self-attestation as well, or open card as well, that it's one of the conditions. So Amelia, you have a couple climate questions in the chat too. I don't know if you want to jump back to those.
Yeah, I'll take those real quick. And then there's one more slide on the home mods portion of housing that I can cover. For energy costs, that is a definite limitation of the HRSN, health-related social needs benefit for climate. We cannot cover the increased utility costs under HRSN. That is a limitation. That's a Medicaid rule. We can't go against the federal Medicaid rule there. I know that that's a limitation. There is an opportunity that folks might, it's not guaranteed, it's not a benefit, might be able to get support under the Flex Funds, Flexible Services through their coordinated care organization. I know there are other utility assistance programs out there that are, they have their own limitations. For utility assistance on housing, I'll just mention again that is only associated with those that are receiving rental assistance. So those are tied together there. You mentioned heat pumps. Heat pumps are fantastic. There are technically portable versions. It's a broad definition what falls under a heat pump, but we are really talking about the portable units. So they must be vented through a window. We can't modify walls or drill through the side of someone's house. Those are not allowed under the climate benefit. But if there's a standalone unit that vents out the window that does both heating and cooling, yes, as long as that is under the actual device cost limits, they should be. We can go up to over $1,000 on these types of devices. So you could get a standalone unit that does heating and cooling, vents out a window, and that would be allowed. Yep. Yeah, so the ones that are standalone, like micro, that yeah, you could move to different rooms or take with you if you moved, as an example. Absolutely, those can be covered.
And then Amelia, there was is it possible for multiple people in the same household to qualify for devices?
That is correct, yes. So these are member level benefits. So if for each OHP member that would be eligible and meet those criteria, they can receive one of each device type. So I also like to give the example of a child who has a shared custody situation. So they reside in 2 homes. That is an exception to our 1 per type limit, that that child could have, say, an air filtration device in both locations because they have 2 living situations. CCOs can approve that. So great questions. Yes. Yeah, and so you had 2 OHP members that shared a space. Each were qualified for an ACE unit in their 2 bedrooms? Like, yes, it's per member. Great questions. Okay, I'm gonna go to the next housing slide. I wanna give chance for Trissa to talk about like that helping piece of connecting people to the benefits. But to get there, let's talk about home modifications first. So here, we're kind of flipping the model a little bit, but I think it makes sense why. We start with clinical risk factor here, because the home modification needs to be tied specifically to the health condition that we're trying to assist with. So I keep going back to like accessibility ramps, because I think that's an easy example. But somebody who might use a mobility device, like there's that clear connection to their health condition of why they need the home modification of having the ramp installed. So that's why we start with clinical risk factor here first. For home modifications, this is where we have these covered populations. You saw the same ones for climate. We have the full list for home modifications. So this is wider eligibility than the rental assistance. And then the last piece is kind of a repeat of what I said, but this must tie to their health condition. They must have a need for this modification to help with their health condition. And then an update that we're putting on the slide, but I didn't get in time for this presentation, is we do need to have landlord approval to make these modifications. So going back to that kind of getting everything ready ahead of time, maybe some of the tenancy support services to have those conversations with a landlord. But just wanted to call that out, that that is another requirement, is that there does need to be a landlord agreement to have this modification done. All right, I think we got a lot of questions in, but I'm pausing again because that is technically that last chunk of the big housing middle piece. I'll see if there's any other questions that pop up before I hand it to Trissa to take it home with outreach and engagement. I guess just I've said it like a lot of times. I'm sorry for repeating myself. November 1st. These are not currently live, but that is going live November 1st. We are still in the getting ready to deliver these services, part of the information sharing, helping kind of spread the word that these will be coming November 1st.
And we are really excited because we just got our contracts and rules are in public comment period right now. And so things are starting to wrap up and we have a good understanding of what's going to happen in November. Well, as good as
like we can actually see, like,
yeah,
it's there, November 1st. I can actually, like, it's getting close, less than 60 days.
It's exciting. It's so exciting. It's going to be tomorrow. That's what it's going to feel like. So I'm going to talk a little bit about outreach and engagement, and I'm going to go back to the landlord approval being required for home modifications or remediations, because that could be an interesting process. And the coordinated care organization or open card should work, work to support the member or a provider if they're helping the member as well with this. But what you could use if you were an HRSN service provider is outreach and engagement to get paid for some of that work as well. There's also tenancy supports, and they are sort of in line as they move forward. There's similar activities. And I'll talk a little bit about tenancy services as well in just a sec. But outreach and engagement services, there is no authorization required. There is this definition, and I'm going to skip ahead really quick because I think this just fits in well here. Oh no, I don't have it on a slide. Okay, I'm just going to speak to it then. Apologies. And I will add a slide into this so you have it for reference later. But there's this idea of presumed eligible for HRSN services. So as an HRSN service provider, you can say, I know this member is an Oregon Health Plan member. That's required. You've confirmed the enrollment. But then I talked to them, a few weeks ago, and they said that they had one of these clinical risk factors. You don't need to go back to the member and ask them to attest to that or go find documentation of that. You can say, I have heard that, I believe that, so I'm going to presume they're eligible. I also know that they were in the child welfare system as a child, so I am going to say that they're eligible for outreach and engagement services, and I'm going to bill their coordinated care organization or open card. And so what that does is it puts the burden well, there's a little bit of burden on the HRSN service provider, but hopefully the healthcare system in general versus the member. The member might not really know they're receiving this specific benefit of outreach and engagement services because it looks similar to other ones. But this is where the HRSN service provider can get paid for these services that they may already be providing, but may have to fundraise for it or apply for grants, which they could still do. But this is a way that hopefully what we see this benefit as fitting in gaps to support the community being more sustainable for these resource connections. So the goal of this outreach and engagement benefit is to invest in the community in a culturally specific or responsive way as well. We want community-based organizations that serve our historically underserved folks. We want those type of people to apply, those type of organizations or people, I suppose, could apply. And then their major role is going to be connecting people maybe to HRSN services like climate housing, but also to things like non-medical or medical services, maybe connecting them with their primary care physician and helping them actually set up that appointment, maybe connecting them to legal aid or peer support services, things like that. So the outreach and engagement services is really a behind the scenes type benefit, and it's intended to help support members' access to other resources and connections, but that's the main goal, but to invest in our community is a huge part of this. So, and it's intended to be low barrier, low barrier, high access. I'm sorry. Wait, no, we don't want it to be high barrier. We want it to be low barrier, so people that are eligible can access these services. These activities are what you could get paid for as an HRSN service provider. So I'm not going to read through all of these, and you'll get these, and it's just hard to remember all of these anyway. It's a very wordy list. But suffice it to say, there's a lot of things here. You can help members maintain their enrollment in the Oregon Health Plan. So they have to already be an Oregon Health Plan member. So you couldn't get paid for getting them on the Oregon Health Plan, but you can help with their redetermination paperwork, maybe their income paperwork that needs to be sent to the Oregon Health Authority to make sure they actually continue to get health care. You can help connect them to things like showers. You could have unhoused folks that are eligible here, and you're supporting them, getting them to shelters, getting them to showers or things that they may need. So this is a pretty, if you look at this list, you actually can mostly just boil it down to you can help a member do anything. It seems like that will increase their well-being, their health, or help them maintain health. So the next slide here talks about eligibility as well. We wanted to make sure that we follow the same framework. So we have this HRSN covered population. We have any clinical risk factor in any framework around health-related social needs. This is not an all-inclusive list. There are more things on it as well. In future presentations, and we will send this out to Heather as well, we are going to have a list of the complete clinical risk factor list, but it's a lot. There's a lot of codes associated and all of that, and that's not the most fun. But you as an HRSN service provider should not have to specifically go track down these codes or anything like that. But knowing that this member has one of these, and again, it can be one of, it doesn't have to be the specific one if they talk with you about it as well. And then the additional eligibility requirement is pretty straightforward like other ones. And a CMS requires to have this social risk factor. That's what this essentially is. And it's just, they need outreach and engagement services. So they need something on this list to be supported for their health and well-being. I'm not going to spend time here talking about this. Yep, we have a very short time. I just wanted to say again, I said it, but this is in writing, does not require service authorization. So if you believe that this member is eligible for services, you can provide services to them as long as you're enrolled as an HRSN service provider. That's the big caveat there. And so I'm not going to talk about that one, but you'll have it for reference if you'd like. It's just a little bit of a flow here that lays out what it's like to be an HRSN service provider. Yes, we will get a copy of this, but I want to call out this page here because there's a service provider link to this web page here, and it talks about enrolling as a service provider and what that takes and how to apply. And then there are some other things like fact sheets, etc., that may help become an HRSN service provider. Okay, yes, you will get a copy. I can't believe we spent a full hour. This has been so fantastic, and I know we are done, so I'll turn it back over to Heather. Heather will give you our email addresses, because I would love if you reached out to me. That'll come up in the follow-up email I think Heather sent. So
Yes, thank you so much. In the last 30 to 45 seconds of our meeting, I want to thank you all for coming. I want to thank you all for being really engaged in asking some really amazing questions in the chat. I think this conversation has the potential to go all the places, and continuing to bring the lenses that you all are using of the impact this is going to have on communities, and the passion around how do we make sure that people's needs are being met, is why we're here. So look for that follow-up email. I will need a minute to get everything converted and the links and all, make sure everything's correct. So thank you for your patience with me in advance. And please, when you have more questions, reach out to Amelia, Krista, Tara. Thank you for being here. And I hope that you all have a lovely day and that you are able to stay cool if you are in a part of the state that it is not going to be cool today. So thank you for coming. We will see you next time.